pulmonary edema. You all are now the master, I would say. You all will not be able to forget, right? I've already shown you so many examples now. Um, Over here, one of the important things which I really wanted to highlight was about the cardiogenic pulmonary edema or the non-cardiogenic pulmonary edema, ARDS, that is what is called as. So it is very important to diagnose that. And why am I talking about this is because a lot of times, especially if a patient is there in the ICU, so you will have to differentiate between those two, because when you want to do the prognostication of the patient, or even if you want to initiate the treatment or the therapy for the patient as well, you should be able to differentiate it. So for example, if it is a cardiogenic pulmonary edema, so of course the heart size is going to be enlarged. However, in the ARDS, acute respiratory distress syndrome, so in which the mean etiology is lying in the lungs, so here the heart size is going to be normal. Similarly, about the vascular distribution, if you are going to look, it is going to be either balanced or in fact inverted as well. In the ARDS, the vascular distribution is almost normal or balanced in fact. Similarly, the edema, if you try to talk, in the heart, the cardiogenic cause, it is more even or central in fact. The edema is going to be. However, in the respiratory cause, the edema is going to be much more widespread. So, for example, you are able to at least see some clear lung zones and all. Over here, not at all. You can't see anything at all, in fact. So, as I was telling you, pleural effusions, yes, quite a lot. It's pretty common in the LV failure. However, in the ARDS, mostly it is not usually present. And the septal lines or even the peribronchial cuffing is pretty much common in the cardiogenic pulmonary edema, in fact. Okay, and the ear bronchograms is most commonly seen in the ARDS. So now you are able to understand not just the to be able to differentiate the ARDS, but also from the different causes, right? So, for example, if it has been caused by the lung problem or is it caused by something else? So, what about hemithorax? So, what is happening over here? Can anyone recall? Okay, let's try to make it easier for you. So, what is happening over here? So, this is the condition. What is happening is hemithorax. And why is it called as hemithorax? Because right, right. So what is happening is you can see only the half of the thorax. So that is why it is called as hemithorax. So there are three different things which you can see. So the mediastinum can be pushed away from the opacification. So this is the opacification, right? This is the opacification. So the once it can be mediastinum is pushed away from the opacification. Second can be is towards the opacification. For example, in this, if you'll notice, and this as well, towards the opacification. Otherwise, the third thing is going to be is it will remain in the middle. Okay, so these are different types of opacification. So in this is remaining in the middle, and this is getting pushed towards the opacification, right? And in this, it is away, right? So these are the three types. So what are those three types? So it is going to be pushed away from the opacification. For example, this is the first type. So this could be is a pleural effusion if there is a large lung mass, otherwise if there is a diaphragmatic hernia as well. So that is where it is going to be pushed away. However, it is going to be pushed towards the towards the opacify side. So, for example, if you look over here in the last X-ray, if there is a lung collapse, there's a pneumonectomy, otherwise also pulmonary hypoplasia, or there's a pulmonary agenesis as well. So then you will be able to see this towards the opacified side. And the last one, as I was telling you, so it remains in the middle. In terms of consolidation, if there is a pleural chest wall mass, otherwise also there can be some combination of pathologies as well. So these were some of those beautiful examples. Oh, so what is this one? So already I have given the diagnosis. Pneumothorax. Why? Why is it pneumothorax? Now the question comes is, why is it pneumothorax?
Air in the thoracic cavity, sir.
Great, great. And what else? So what happens is you should try to look for the outer margin, exactly, the outer margin of the visceral pleura and lung. So what is the pleural line? If you are able to see the pleural line, run, 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 emergency. You should try to immediately start arranging the things with which you are going to intervene. So a lot of times a procedure has been done, ablation procedure is done, otherwise um, yeah, exactly. Yes, yes. So cath procedure has been done, and then patient complains, shortness of breath and all. Then you get this X-ray. So this is the time for action. So this is how you differentiate. As I was telling you, if you are able to demonstrate the outer margin of the visceral pleura and lung, the pleural line, from the parietal pleura. Parietal pleura and visceral pleura is different. So if you are able to see this line, then this is what is the classical pneumothorax. Okay, now hydropneumothorax. Come on, try to understand the English. Hydropneumothorax.
Any chylous fluid or any kind of fluid in a pleural cavity.
Okay, good, good. But how do you
Fluid
see?
and air.
Exactly. So you are able to see not just air, but also fluid as well. So do you notice the straight line here and the straight line over here? And you should ideally do in a upright chest X-ray. So you are able to see it's a huge, not just air is there, but also fluid as well. So this is hydro. Pneumothorax, you are already the masters now. Pneumothorax, you know hydro is also there now. Okay.